This presentation are going to be to differentiate between major causes of hyperthermia, identify key clinical features that guide diagnosis and treatment. We're going to evaluate the pharmacologic and non-pharmacologic treatment strategies for hyperthermic emergencies, and we're going to interpret relevant primary literature supporting therapeutic interventions. Here are abbreviations for this presentation. We're going to start off with a patient case. This is a 25-year-old male found by friends at an all-night Halloween music festival with confusion and agitation. On EMS arrival, he was combative with a generalized seizure that required intubation for airway protection. He was intubated using midazolam and succinylcholine. Upon arrival to the ED, some of the initial vitals were a temperature of 104.5 degrees Fahrenheit, a heart rate of 135, blood pressure 160/95, and a respiratory rate of 28. Physical exam after the sedation revealed profuse sweating, generalized muscle rigidity, dilated pupils, and occasional tremors. There's no obvious trauma or infection, and his glucose is normal. And we will revisit this case later on. Let's first talk about the pathophysiology of hyperthermia. Hyperthermia reflects an imbalance between heat production and heat dissipation, and we can categorize it into three major mechanisms. The first mechanism is the failure of central thermoregulation, like dopamine blockade and neuroleptic malignant syndrome or excess serotonin signaling. You can have excess heat production, which is seen with exertional heat stroke, stimulants, and malignant hyperthermia. Or you could have impaired heat dissipation. This is seen in anticholinergic toxicity or dehydration in a hot environment. So understanding the underlying mechanism can help you tailor your management. So hyperthermia becomes life-threatening largely because of the cellular and systemic consequences of an elevated temperature. Protein denaturization and enzymatic dysfunction occur at temperatures that are approaching 105 degrees Fahrenheit. You can have mitochondrial dysfunction and oxidative stress, which contribute to cellular injury and multi-organ failure. And then with rising temperatures, lipid membranes can become unstable and generalized inflammation is common, which can lead to gut barrier breakdown. Endothelial injury causes tissue factor expression, which can lead to coagulopathy and DIC. And some downstream effects include renal and hepatic injury, cardiovascular collapse, and CNS dysfunction. So these complications kind of highlight the urgency of rapid and aggressive supportive care. When faced with a hyperthermic altered patients, there are several differentials to consider. Some major ones include heat stroke, which can be exertional or environmental, infection, thyroid storm, and drug-induced hyperthermic syndromes, which we'll review during the rest of this presentation. So going back to our patient case with our 25-year-old male, after the patient's initial presentation, which of the following is the least likely cause of this patient's hyperthermia? Is it A, malignant hyperthermia, B, serotonin syndrome, C, neuroleptic malignant syndrome, or D, heat stroke? The answer is D, it's heat stroke is the least likely. Although this was an outdoor event, his presentation was not consistent with exertional or classic heat stroke, especially given the rigidity and tremors that he was experiencing. The first disease state we'll be discussing in more detail is malignant hyperthermia. Malignant hyperthermia is a rare pharmacogenetic disorder involving impaired calcium regulation within skeletal muscle. Most cases originate from a mutation in the ryanodine receptor, or RYR1, which is inherited in an autosomal dominant pattern. This mutation predisposes the sarcoplasmic reticulum to uncontrolled calcium release when exposed to specific triggers. This calcium surge leads to sustained muscle contraction, excessive ATP consumption, and profound heat generation, which ultimately leads to the hypermetabolic state, which is central to malignant hyperthermia. Volatile anesthetic gases such as isoflurane and sevoflurane are classic triggers for malignant hyperthermia. These agents enhance CNS inhibition through increased GABA activity and decreased NMDA activity, and that produces amnesia and immobility. In patients with an RYR1 mutation, exposure results in abnormal receptor activation and uncontrolled calcium release. This results in sustained contraction and hyperthermia. And so most perioperative malignant hyperthermia episodes occur in this context. Succinylcholine is another major trigger of malignant hyperthermia. Under normal circumstances, it binds acetylcholine receptors, causing transient depolarization and fasciculations followed by paralysis. In malignant hyperthermia susceptible patients, the depolarization also activates the dysfunctional RYR1 receptor, leading to massive uncontrolled calcium release. Malignant hyperthermia classically presents with a triad of rapidly rising end-tidal CO2, muscle rigidity, and hyperthermia. Acidosis quickly develops from the hypermetabolic state, and both metabolic and respiratory components can be seen. Hyperkalemia results from skeletal muscle breakdown, and creatinine kinase levels can become profoundly elevated. And myoglobinuria is an important early indicator of rhabdomyolysis. And so prompt recognition of all of these symptoms is vital to prevent cardiovascular arrest and multi-organ failure. So discussing more about management. Your acute management begins with immediate discontinuation of all triggering agents, if possible. The cornerstone of therapy is rapid administration of IV dantrolene. So dantrolene inhibits abnormal calcium release from the sarcoplasmic reticulum. And this halts the hypermetabolic cascade that has all the lasting sequelae. The recommended dose is 2.5 mg per kg IV, and this can be repeated every 5 minutes until your symptoms resolve. A lack of response after 10 mg per kg should prompt you to reassess the diagnosis of malignant hyperthermia. Key adverse effects include hepatotoxicity, muscle weakness, and sedation. And it also interacts with non-dihydropyridine calcium channel blockers and other CNS depressants. Another aspect of management is hyperventilation with 100% oxygen, which can help correct hypercarbia and respiratory acidosis. Next, we'll address the complications associated with the hypermetabolic state. If a patient is experiencing metabolic acidosis, you should treat with sodium bicarb, 1 to 2 mg per kg, if the blood values are still pending and acidosis is strongly suspected. If the patient is hyperkalemic, you want to administer 10 units of insulin with dextrose and give calcium chloride or gluconate to stabilize the myocardium. Dysrhythmias often improve once acidosis and hyperkalemia are corrected. So importantly, you want to avoid calcium channel blockers, which can precipitate hyperkalemia and cardiac arrest when it's given with dantrolene. And cooling measures should be initiated concurrently. So even though dantrolene corrects the underlying physiology, external cooling remains necessary until core temperature normalizes. Patients require ICU monitoring for at least 24 hours following resolution of the acute episode. And up to 25% of patients experience a return of the hypermetabolic state within 48 to 72 hours. Repeat dosing of dantrolene may be required either at 1 mg per kg every 4 to 6 hours or a continuous infusion at 0.25 mg per kg per hour. And close lab surveillance is essential. So this includes your end-tidal CO2, electrolytes, blood gas, CK, coagulation markers, urine output and color, and serial core temperatures. So ongoing monitoring ensures early detection of rhabdomyolysis, DIC, renal injury, and recurrent hypermetabolism. The first study we'll look at is the landmark Kolb and colleagues study. This is published in Anesthesiology in 1982. So this was the first human study confirming the efficacy of dantrolene in malignant hyperthermia. Before dantrolene became widely available, mortality for malignant hyperthermia was estimated at 70 to 80% despite supportive measures. And animal studies had already shown that dantrolene could inhibit abnormal calcium release from the sarcoplasmic reticulum, but this study provided clinical evidence in humans. Key outcomes included resolution of malignant hyperthermia, symptoms, and survival in patients who received timely dantrolene. Looking more closely at this study, starting at the top, There were 21 patient cases that evaluated patients who received dantrolene within the first 6 hours. And these patients either had unequivocal case of malignant hyperthermia or a probable case. This group of patients had really great outcomes. All 11 survived with no lasting sequelae. In contrast, the 4 patients with unequivocal malignant hyperthermia where dantrolene was delayed beyond 6 hours, the mortality decreased to 75%. And there's also 6 patients in whom malignant hyperthermia was ultimately deemed unlikely, but who still received dantrolene. And all of them survived without adverse drug reactions. And so this kind of pattern supports 2 important concepts. One is that early administration of dantrolene is critical, and the risk of giving dantrolene empirically when malignant hyperthermia is suspected is relatively low compared to the risk of undertreatment. From a systems and pharmacy operations standpoint, having a fully stocked malignant hyperthermia cart is essential. The cart should contain adequate supply of dantrolene vials along with sufficient sterile water for reconstitution with clearly labeled mixing instructions. Adjunctive medications typically include agents to manage hyperkalemia and acidosis, such as sodium bicarb, insulin with dextrose, and calcium, as well as medications for arrhythmia management. Cooling supplies and clear dosing and management algorithms should also be readily available. Pharmacists play a key role in maintaining inventory and monitoring expiration dates and ensure that staff should know where the cart is located and how to use it in an emergency. To summarize, malignant hyperthermia is a pharmacogenetic disorder triggered primarily by volatile anesthetics or succinylcholine. Onset is usually within minutes after exposure, often during or shortly after induction of anesthesiology or intubation. Clinical hallmarks include rapidly rising end-tidal CO2, generalized muscle rigidity, hyperthermia, hyperkalemia, and elevated creatinine kinase. Management centers on immediate administration of dantrolene, 2.5 mg per kg, repeated until symptoms improve, alongside progressive supportive care and cooling. Early recognition and prompt therapy is strongly associated with improved survival and reduced long-term complications. For our next knowledge check, you are going to be learning more about your patient. During the EMS report, they mentioned that they were intubated using succinylcholine, which raises your concern for malignant hyperthermia. What is the mechanism of malignant hyperthermia? Is it A, dopamine receptor blockade in the hypothalamus, B, excessive serotonin 2A receptor activation, C, uncontrolled calcium release from the sarcoplasmic reticulum, or D, muscarinic receptor blockade at the sweat glands? C. Correct answer is C. It's uncontrolled calcium release from the sarcoplasmic reticulum. Next, we'll be discussing neuroleptic malignant syndrome, or NMS. NMS is a rare but life-threatening reaction to dopamine D2 receptor antagonists, or alternatively to withdrawal of dopaminergic medications. The core pathophysiology is extreme central dopaminergic blockade in the hypothalamus, leading to impaired thermoregulation and dysautonomia. It was first described with first-generation antipsychotics such as haloperidol, but second-generation antipsychotics have also been implicated. NMS typically develops within the first 1 to 2 weeks of starting or significantly increasing a dopamine blocking drug, and symptoms evolve over 1 to 3 days rather than minutes. Risk factors include high doses, rapid dose escalation, and the use of depot or injectable formulations, with dehydration and agitating further increasing your risk. First, we'll discuss the D2 receptor antagonists, which are the most common medications to precipitate NMS. These include typical antipsychotics such as haloperidol, which has the largest number of reported cases, as well as atypical antipsychotics. NMS can also be seen with D2 blocking antiemetics like prochlorperazine, promethazine, and metoclopramide. Withdrawal of exogenous dopamine can also be a precipitating factor of NMS. Abrupt discontinuation of dopaminergic Parkinsonian medications can lead to a similar picture, sometimes referred to as Parkinsonism hyperpyrexia syndrome. Active withdrawal of dopaminergic stimulation, such as cessation of chronic cocaine use, has also been described as a trigger in NMS. NMS classically presents with four main clinical domains. Mental status changes are often the earliest feature, and they present as agitated, delirium, or confusion. Muscle rigidity is generalized, severe, and characteristically described as lead pipe rigidity, which helps distinguish NMS from serotonin syndrome, where clonus and hyperreflexia predominates. Hyperthermia also occurs in the vast majority of cases, with temperatures above 100.4 degrees reported in roughly 90% of cases. Lastly, autonomic instability includes tachycardia, hypertension, tachypnea, and profuse diaphoresis. The combination of a recent dopamine-blocking drug exposure plus this clinical constellation should raise strong suspicion for NMS. Laboratory abnormalities and NMS largely reflect the muscle breakdown and systemic inflammation. So your CK is typically elevated and can be markedly high. Leukocytosis is common and it can be misleading as it may suggest infection. Electrolyte abnormalities, particularly hyperkalemia, may occur due to the muscle breakdown. And myoglobinuria is another clue pointing towards significant muscle injury. The first and most important step in management is immediate discontinuation of the offending agent or reinitiation of the dopaminergic therapy if withdrawal was the trigger. Supportive care is the backbone of management. You want to use active cooling measures for hyperthermia like a cooling blanket, ice packs, evaporated cooling, and cooled IV fluids as needed. You want to intubate if muscle rigidity or mental status compromise ventilation or the patient's ability to protect their airway. And you want to correct electrolyte disturbances, avoid nephrotoxins, and trend CK closely to monitor for rhabdomyolysis. Benzodiazepines are useful adjunct agents as they reduce agitation and provide a mild central muscle relaxing effect. And if the patient is experiencing ongoing agitation, you want to avoid additional antipsychotics. So central alpha-2 agonists such as dexmedetomidine are preferred because they provide sedation and sympatholysis without adding further dopamine blockade. For moderate to severe NMS, pharmacologic agents that restore dopaminergic tone can be added. So the first one we'll discuss is bromocriptine. It's a direct dopamine agonist, typically dosed 2.5 to 5 milligrams orally every 8 hours with a maximum dose of 40 milligrams a day. Due to its extensive first-pass metabolism, you want to use caution in patients with liver impairment. And therapy is usually continued for 7 to 10 days after clinical resolution, and it's followed by a slow taper to prevent relapse. Adverse effects include nausea, vomiting, dyspneas, hypertension, and with long-term use, a risk of fibrotic complications. And there's also the risk of CYP3A4 drug interactions as well. Amantadine works indirectly to increase dopaminergic activity and rebalance dopaminergic and cholinergic tone. Typical dosing is 100 milligrams orally once daily, titrated up to a maximum dose of 400 milligrams daily in divided doses. And this medication does need to be renally dose adjusted. It should also be discontinued with a gradual taper. Adverse effects include anticholinergic symptoms, orthostatic hypotension, syncope, and a reduced seizure threshold. Amantadine can be used when bromocriptine is contraindicated or in combination with severe cases. Dantrolene, which we discussed with malignant hyperthermia, can also be used as an adjunctive therapy in NMS. Its mechanism is direct skeletal muscle relaxation through inhibition of calcium release from the sarcoplasmic reticulum, like we discussed, which may reduce the rigidity and hyperthermia seen in NMS. However, it does not address the underlying dopaminergic deficit, so it should not be used as monotherapy. Dosing in NMS is less clearly defined. Reported regimens range from 1 to 2.5 mg per kg every 6 to 8 hours, up to a maximum dose of 10 mg per kg per day. with no clear indication for bolus dosing like we see in malignant hyperthermia. In refractory NMS, electroconvulsive therapy is a last line option, which has been associated with clinical improvement when pharmacologic therapy alone is insufficient. Oh, I think we skipped a slide. No. Next, we'll be reviewing a large systematic case series by Cullum and colleagues published in 2020. They compiled 405 published case reports of NMS from 1982 to 2019, which allowed comparison between different treatment strategies. The primary outcome of interest were survival rates and duration of treatment. There were 5 different intervention groups: symptomatic therapy alone with no specific NMS targeting treatment, dantrolene alone, bromocriptine alone, the combination of dantrolene plus bromocriptine, and finally electroconvulsive therapy. This table shows the baseline characteristics across the five treatment groups. Patients had a mean age in the 30s, early 40s, and a slight male predominance in each group. Most cases were graded as moderate to severe NMS using the author's staging system seen in the chart below, which was based off of symptoms, temperature, and heart rate. When looking at all NMS severity grades combined together, survival was high across all groups. Symptomatic therapy alone resulted in about a 90% survival, while NMS-directed pharmacotherapy, which included the dantrolene group, the bromocriptine group, or their combination combined, all had a very similar survival rate, around 90 to 92%. And then all patients treated with electroconvulsive therapy in this data set survived, although the number of patients in this group was smaller. Overall, when mild, moderate, and severe cases are all pooled, there was no significant difference in survival between the supportive care group and the NMS targeted therapy. And so this suggests for milder presentations, high quality supportive care may be sufficient. This picture changes when we focus only on severe NMS cases. So among severe cases, survival with symptomatic therapy alone was about 70% compared to 90% in those who received NMS-directed pharmacotherapy and 100% in those who were treated with electroconvulsive therapy. Here, the difference in survival between supportive care and pharmacologic or electroconvulsive therapy was statistically significant with a p-value of 0.018. So this supports the use of dopamine agents like bromocriptine and amantadine with or without dantrolene as an adjunct, as well as consideration of electroconvulsive therapy in severe NMS, rather than relying solely on supportive care. And just to note, electroconvulsive therapy was shown in the study to be highly effective, but its use is limited by resource capabilities of the hospital and appropriateness for the majority of patients. So to close up NMS, these are some of the key points that you should remember. NMS is a rare reaction to D2 receptor blockade or dopaminergic withdrawal, and it typically evolves over days rather than minutes. Lead pipe rigidity and hyporeflexia in the setting of recent dopamine antagonist exposure are characteristic features. Initial management is to immediately stop dopamine antagonists and provide aggressive supportive care. Bromocriptine or amantadine can be used with or without adjunctive dantrolene for severe cases. Next, we will be discussing serotonin syndrome. Serotonin syndrome is a toxidrome caused by excessive serotonergic activity in the CNS. It typically occurs when multiple serotonergic agents are combined after a dose escalation or in the setting of an overdose. Patients may present with serotonin toxicity from interactions involving prescription medications, herbal supplements, or recreational drugs. Nosocomial cases often arise when a new serotonergic agent is added without fully reviewing all the patient's medications. The underlying mechanism is overstimulation of serotonergic 1A and serotonin 2A receptors, centrally and peripherally, and this leads to amplified neuromuscular and autonomic effects plus altered mental status. This diagram highlights multiple points in serotonin signaling where medications can increase synaptic serotonin. So serotonin toxicity can result from decreased serotonin formation, for example, with high doses of L-tryptophan. It can result in serotonin toxicity from increased release of stored serotonin, as seen with amphetamines and some other stimulants. Inhibition of serotonin metabolism via MAOI inhibitors, which raises presynaptic serotonin concentrations. Impaired reuptake into the presynaptic neurons with SSRIs, SNRIs, and TCAs. And lastly, direct serotonin agonists and agents like lithium that can enhance postsynaptic responses to serotonin. So most clinical cases involve more than one of these mechanisms acting together. Some trauma drug classes that are associated with serotonin syndrome are MAOIs, including isosonide, linazolid, and methylene blue. They're high risk because they block serotonin breakdown. Antidepressants such as SSRIs, SNRIs, and TCAs are frequent contributors, especially when combined with other agents. Over-the-counter or herbal products like St. John's wort, L-tryptophan, and dextromethorphan are often underreported, but are clinically important. Antiemetics like metoclopramide and ondansetron, and analgesics like fentanyl, tramadol, meperidine, and methadone also carry serotonergic activity. And pharmacists should pay particular attention to the combination of medications across several of these different classes rather than just a single agent by itself. Serotonin syndrome is best remembered as a triad of neuromuscular hyperactivity, autonomic instability, and mental status changes, with severity ranging from mild to life-threatening. Neuromuscular hyperactivity is seen with brisk reflexes and inducible clonus. In mild cases, progressing to sustained clonus and tremor, and ultimately rigidity and respiratory failure and severe toxicity. Autonomic features include nausea and diarrhea early on, and then hypertension, tachycardia, flushing, diaphoresis, and severe hyperthermia as severity increases. And mental status changes are often seen with insomnia and anxiety, and can progress to agitation, confusion, and ultimately hypoactive delirium or coma. The Hunter serotonin toxicity criteria is the most widely used diagnostic tool for serotonin syndrome. First, there must be a history of serotonergic agent ingestion or overdose. From there, the algorithm focuses heavily on clonus and hyperreflexia. Spontaneous clonus alone is sufficient to diagnose serotonin syndrome. Or if the patient does not have spontaneous clonus, if they have inducible or ocular clonus in combination with agitation, diaphoresis, or hypertonia plus fever, that can also diagnose serotonin syndrome. If clonus is absent, tremor with hyperreflexia can also meet criteria. The key takeaway is that clonus and hyperreflexia are central to the diagnosis of serotonin syndrome and can help differentiate it from NMS, which is characterized by rigidity and hyporeflexia. Management principles are similar to other hyperthermic syndromes, but with important serotonergic specific considerations. First and foremost, you want to stop all the offending agents. Serotonin syndrome usually develops rapidly and often improves quickly after the offending agents are withdrawn. You want to carefully review the inpatient and home medications to ensure that you're not inadvertently reintroducing serotonergic agents. Intubation may be required for severe agitation, hyperthermia, or respiratory compromise, but you want to avoid using succinylcholine due to the risk of worsening rhabdomyolysis, and you want to avoid using fentanyl because of the serotonergic properties. For pain control, you want to choose opioids with minimal serotonergic activity, such as morphine, oxycodone, or hydromorphone. For agitation, benzodiazepines and dexmedetomidine are preferred. Chlorpromazine, which blocks serotonin 2A receptors, may be beneficial for refractory agitation or nausea, but needs careful monitoring for hypotension and QTc prolongation. And as with other hyperthermic states, you want to monitor their electrolytes, CK, and renal function for evidence of rhabdomyolysis or AKI. Cyproheptadine is the primary pharmacologic antidote used in serotonin syndrome. It's a first-generation antihistamine with potent antagonism at the serotonin 2A and 2C receptors. These are the receptors that are most involved in severe serotonin toxicity. It's recommended for moderate to severe cases, particularly when agitation and neuromuscular findings persist despite this removal of the offending agent in supportive care. The typical dosing strategy is 12 milligrams once, followed by 2 milligrams every 2 hours as needed, up to a maximum dose of 32 milligrams daily. Adverse effects include sedation, hypotension, and anticholinergic effects such as dry mouth and urinary retention. You want to use caution with concurrent MAOI inhibitors, which can prolong cyproheptadine anticholinergic side effects and further complicate the clinical picture. Next, we'll discuss a small retrospective study by Prakash and colleagues looking specifically at cyproheptadine use in serotonin syndrome. They reviewed 23 adult patients who met Hunter criteria for serotonin syndrome and were admitted for management. The primary objective was descriptive. It was to observe how cyproheptadine affected the clinical characteristics over time. They included patients that were 18 years or older that were admitted with serotonin syndrome and excluded those with significant chronic morbidities such as diabetes or hypertension to limit confounders. This graph shows the most common presenting features among the 23 patients. Hyperreflexia was present in all patients and clonus in over 90%, which aligns with the Hunter criteria emphasis on clonus and brisk reflexes. Of the 23 patients included in the study, 10 were admitted to the ICU. Of those 10 patients, all had fever, abnormal mental status, and diaphoresis. Here are the serotonergic medications most commonly implicated in these cases. Tramadol was the leading agent at 39%, followed by valproic acid and amitriptyline, each in about 1/5 of patients. Only 1 out of the 23 patients was on a single anti-serotonergic drug. Most were on at least 2, and many were on 3 or more agents. Notably, this study, all doses were in therapeutic range, and none of the patients were experiencing an overdose. So this kind of underscores the fact that serotonin syndrome often results from drug interactions between serotonergic drugs at usual doses rather than overdose. Next, we'll discuss how cyproheptadine was dosed in the study, stratified by the ICU and ward locations. The ICU patients received a more aggressive regimen, which was a loading dose of 12 milligrams, and then 2 milligrams every 2 hours as needed if symptoms persisted. And then this was then followed by a maintenance dose of 8 milligrams every 6 hours. Ward patients started on 4 milligrams orally 3 times a day with titration based off a clinical response. So these regimens are broadly consistent with current recommendations, and they kind of provide a practical framework that you can decide how aggressively to dose cyproheptadine based on the patient's severity and the level of care that they're receiving. So this slide summarizes the clinical changes 24 hours after starting cyproheptadine. Clonus, which was present in 21 out of 23 patients at baseline, completely resolved in 11 out of patients and decreased in the remaining 10. Rigidity, where spasticity was present in 15 patients and improved in 11 of them. Fever and diaphoresis decreased in all ICU patients, and altered mental status improved in more than half of those who initially had it. In the post-acute phase, cyproheptadine was gradually tapered over 5 days to 2 weeks at the provider's discretion. So this study had a few strengths. They used diagnostic criteria, standardized diagnostic criteria with the Hunter criteria, and they had fairly consistent dosing strategies with clear reporting of the clinical outcomes over time. However, the limitations are pretty significant. This is a retrospective case series with no control group. It was a small sample size, and it had a limited generalizability outside of their practice setting. So while the results support cyproheptadine's role in serotonin syndrome, the study should be interpreted as supportive and not definitive evidence. To wrap up serotonin syndrome with, these are the main points that you should leave with. So first, think of serotonin syndrome whenever there's an excess serotonergic activity from drug interactions or overdose. You want to clinically look for the triad of altered mental status, autonomic hyperactivity, neuromuscular excitation, and especially clonus and hyperreflexia. Management centers on stopping serotonergic agents, providing supportive care, and using cyproheptadine for moderate to severe cases at 12 milligrams once, followed by 2 milligrams every 2 hours as needed, and then transitioning to a maintenance regimen. This is your knowledge check 3. You later talk to the patient's family and friends who report he was prescribed sertraline for depression, and while he was at the music festival, he took MDMA. On exam, you see sustained clonus. Which combination of pharmacologic mechanisms best explains this patient's presentation? Is it A, increased dopamine and norepinephrine reuptake inhibition, B, additive serotonin reuptake inhibition and serotonin release, C, monoamine oxidase inhibition and dopamine depletion, or D, muscarinic receptor blockade and GABA antagonism? B. So the patient is experiencing the additive serotonin reuptake inhibition and the serotonin release as well. Next, we'll be discussing sympathomimetic toxicity. Sympathomimetic toxicity is essentially too much adrenergic stimulation. This can occur from increased release of norepinephrine and dopamine, as with amphetamines and MDMA, or from reuptake inhibition, as we see with cocaine and methylphenidate. MAO and COMT inhibitors impair metabolism of catecholamines, and that further amplifies the response. In practice, we often don't know exactly what is responsible. Many of these are street drugs, which can be contaminated, and patients may be unwilling or unable to provide an accurate history of what they've taken. Because of that, management is syndrome-based rather than drug-specific. So once you recognize the sympathomimetic picture, you treat the physiology. Some of the main drug classes that provide a sympathomimetic toxidrome include cocaine, which is a reuptake inhibitor that increases synaptic catecholamines. Methamphetamine and other amphetamines increase release of norepinephrine and dopamine, and these can be prescription ADHD medications or illicit products like crystal meth. Phenylethylamines include classic amphetamines, but also MDMA or ecstasy or Molly. Catathione, often sold as bath salts, are synthetic stimulants with unpredictable potency and often have adulterants in them. And finally, agents like theophylline are a reminder that not all sympathomimetic toxicity is a recreational toxicity. Therapeutic drugs can also cause toxicity when overdosed or if they're in high serum concentrations. This figure uses recent Substance Abuse and Mental Health Services Administration data to emphasize that stimulant use and misuse is common and is often overlapping. So in the figure on the left, we see a sizable population using cocaine only, methamphetamine only, and a significant group with combined cocaine and methamphetamine use. There's also a large overlap between prescription stimulant use and illicit stimulants. And the figure on the right shows that overall prevalence of CNS stimulant misuse has remained fairly stable over the last few years. So it's not a rare problem. It's something that is encountered often in EDs and ICUs. And so for pharmacists that understand, this kind of underscores the importance of quickly recognizing the toxidrome and anticipating complications like hyperthermia, arrhythmias, and hypertensive emergencies. Clinically, sympathomimetic toxicity is characterized by a highly activated patient. Neurological symptoms can include seizures, psychosis, hallucinations, mania, and paranoia. Mydriasis is common, along with hyperthermia and diaphoresis. The patient may be tachypneic and may be tachycardic and have hypertension as well. They will likely have hyperactive bowel sounds, and tremor is common. The first priority is controlling agitation, both to protect staff and to reduce ongoing catecholamine surge and heat production. Benzodiazepines are the mainstay. Options include midazolam, diazepam, or lorazepam. Antipsychotics such as olanzapine, droperidol, or haloperidol can be added for severe psychosis. And agents like ketamine and dexmedetomidine are useful adjuncts in the ICU setting when benzodiazepines and antipsychotics are insufficient. Agitation control is also a temperature intervention. So if you cannot control the patient's activity you may need early intubation and deeper sedation. In parallel, you want to use physical cooling strategies and continuous monitoring of vitals, EKG, and electrolytes to detect complications early. So cocaine deserves a special attention because of its sodium channel blocking properties, which can produce a wide QRS and a monomorphic ventricular tachycardia that comes with massive intoxication. When the QRS is greater than 100 to 120 milliseconds, it should be treated like a sodium channel blocker overdose with hypertonic sodium bicarbonate at a dose of 1 to 2 milliequivalents per kg every 5 minutes, with a goal of narrowing the QRX complex and maintaining an arterial pH of 7.45 to 7.55. Cocaine can also prolong the QT interval and precipitate torsades. We aggressively replete magnesium and potassium, and any patient who is actively experiencing torsades should receive IV magnesium regardless of what their level is. Hypertension is another common complication. You want to avoid selective beta blockers in these patients because of the risk of unopposed alpha stimulation. That can worsen coronary and vasoconstriction and systemic blood pressure. Instead, you want to rely on benzodiazepines to blunt the sympathetic outflow, and if needed, vasodilators such as nitroglycerin or nitroprusside can be used. This study by Yap and colleagues sought to look at management strategies for treating methamphetamine-related agitation. It's a subgroup analysis from a larger, multi-centered, randomized, double-blind controlled trial looking at IV sedation strategies for acute agitation. The parent study enrolled 361 patients, but this analysis focused on the 92 patients whose agitation was attributed specifically to methamphetamine use. The primary outcome was very clinically relevant. It was whether the patients were adequately sedated at 10 minutes after the first dose. And patients were randomized to one of 3 arms, either midazolam plus droperidol, droperidol alone, or olanzapine alone. Here are the baseline characteristics for the methamphetamine subgroup. Age and sex distribution were similar across the 3 treatment arms, with the mean ages in the early 30s and predominance of male patients, which is consistent with the population commonly seen with stimulant intoxication. A portion of patients received prior sedative therapy before randomization. So this is commonly oral diazepam or oral olanzapine. And also note that 20% of the midazolam droperidol group also received oral olanzapine prior to randomization. The other note is that the midazolam droperidol group had the shortest median duration of security attendance at 29 minutes compared with 41 and 33 minutes. And this suggests that it was more efficient behavioral control and potentially lower resource utilization. This figure shows the proportion of patients who were adequately sedated at 5 minutes at the top set of bars, 10 minutes, and then 30 minutes after the first dose was administered. The midazolam droperidol group combination, which is shown in the darker bars, achieved higher rates of adequate sedation at each time point, particularly at 10 minutes, which is the middle set of bars, which was the primary endpoint. The combination regimen also demonstrated a shorter median time to sedation, which was approximately 5 minutes, compared with 10 to 11 minutes in the droperidol and olanzapine monotherapy groups. The key takeaways for this section regarding sympathomimetic toxicity is that this toxidrome is often due to overdose or intoxication with cocaine, amphetamines, MDMA, or related agents, leading to markedly increased catecholamine activity. Clinically, patients present with agitation, prominent diaphoresis, tachycardia, hypertension, mydriasis, hyperthermia, and findings should immediately raise concern for a sympathomimetic picture. Management is primarily supportive, with aggressive care of agitation using benzodiazepines, with or without antipsychotics, and alongside temperature management and close monitoring for complications such as rhabdomyolysis and cardiac dysrhythmias. And the last toxicity we'll be discussing is anticholinergic toxicity. Anticholinergic toxicity results from an excess blockade of acetylcholine receptors, particularly at the muscarinic receptors in both the central and peripheral nervous system. Centrally, M1 receptor blockade leads to agitation, delirium, confusion, in severe cases, seizure or coma. Peripherally, blockade of M2 and M3 receptors in the heart, glands, and smooth muscle drives the classic findings of tachycardia, dry skin, dry mouth, and mydriasis. The mechanism that drives hyperthermia in these patients is slightly different from other syndromes. Peripheral muscarinic blockade at the sweat glands causes anhidrosis, so the patient cannot dissipate heat. That, in combination with peripheral vasodilation causing warm, flushed skin, leads to an elevated body temperature. The slide summarizes the classic anticholinergic toxidrome. Many of us remember it using the mnemonic seen here. Clinically, this appears as reduced sweating that leads to hyperthermia. Cutaneous vasodilation explains the flushed, red as a beet appearance. Patients have dry skin and mucous membranes, mydriasis with blurry vision, delirium or frank hallucinations, absent bowel sounds and urinary retention, and sinus tachycardia, which rounds out the overall clinical picture. So remembering these features are especially useful when you're trying to distinguish anticholinergic toxicity from sympathomimetic toxicity or serotonin syndrome. Anticholinergic toxicity can come from a wide range of therapeutic and non-therapeutic agents. On the prescription side, you can think about pure antimuscarinics like atropine, glycopyrrolate, and scopolamine, essentially acting agents such as benztropine, and blotter agents like oxybutynin and sulfafinicin. GI antispasmodics like dicyclamine and hyoscyamine also contribute. And this is particularly in older adults that are experiencing polypharmacy as well. And then finally, you should remember that there are plant sources that can cause anticholinergic toxicity. So this includes Jimson weed or Atropa belladonna, and these can present as severe intentional or unintentional overdoses, particularly in younger patients. Likely one of the biggest challenges is distinguishing anticholinergic toxicity from sympathomimetic toxicity because both can present with agitation, tachycardia, hypertension, and hyperthermia. The key differentiating features are moisture and gut and bladder function. Anticholinergic patients are dry. They have dry, flushed skin, urinary retention, and absent bowel sounds. In contrast, sympathomimetic patients are wet. They are diaphoretic with hyperactive bowel sounds and typically no urinary retention. Management starts with supportive care, just like the other syndromes we've discussed. That includes airway protection, IV fluids, temperature management, and treating agitation, usually with benzodiazepines as first line. Treatment of anticholinergic toxicity includes physostigmine, which is a reversible anticholinesterase inhibitor that increases synaptic acetylcholine. And this can reverse both the central and peripheral anticholinergic effects. It's both therapeutic and diagnostic when used appropriately. The typical dose is 1 milligram IV given slowly over 5 minutes with the option to repeat every 10 to 15 minutes if symptoms persist while monitoring on telemetry. You want to stop if the patient develops bradycardia. Importantly, physostigmine is contraindicated in TCA overdose or if the EKG shows QRS or PR prolongation because of the risk of precipitating arrhythmias. And side effects are essentially anticholinergic excess, bradycardia, increased secretions, and rarely seizures. In the 1970s, physostigmine was incorporated into the coma cocktail for undifferentiated toxidromes, which meant it was often given without a clear diagnosis of anticholinergic toxicity. In the 80s, case reports of seizure and asystole, particularly when physostigmine was used in TCA overdose, led to significant concern that then the drug completely fell out of favor. As a result, its use really declined in most centers across the states. By the late 1990s, Poison Center data suggested that a very small percentage of patients with moderate to severe non-TCA overdoses were receiving physostigmine, which prompted a reevaluation of its role. This study by Burns and colleagues was published in 2000 and was one of the foundational comparative analysis evaluating physostigmine versus benzodiazepine specifically for anticholinergic toxicity. It was a retrospective single-center review of 52 patients who presented with agitation or delirium due to anticholinergic toxicity. The primary objective was to compare both the efficacy and safety of physostigmine related to benzodiazepines for the treatment of agitation or delirium and anticholinergic toxicity. So physostigmine was used as first line at 1 to 2 milligrams IV with repeated dosing every 5 minutes as needed. Benzodiazepines served as either adjunctive therapy or as an alternative when physostigmine was contraindicated. Most anticholinergic overdoses in this cohort were due to diphenhydramine, which accounted for nearly half the cases. So the other agents that were commonly seen were listed here as well. When looking at the breakdown in treatment groups, about 86% received physostigmine at some point during their encounter, and then half of those also received benzodiazepines. So this overlap kind of represents real-world management because benzodiazepines are often used first line. So in this study, the investigators used this slide, this rating scale, to quantify the level of agitation or delirium. The scores range from 0, representing relaxed cooperative state, to 4, which reflects seizure or deep coma. And so here we see the key findings. Patients were originally treated with physostigmine had dramatic improvement in CNS scores, dropping from 2.5 to 0.1 as seen in the first box on the left. In contrast, patients treated with benzodiazepines initially improved much less. Their mean post-treatment scores remained elevated at 2.3 when benzodiazepines were used initially. So if you remember how the study was designed, many patients received both physostigmine and benzodiazepines, which may muddy the picture when interpreting results. However, when analyzing the patients who received only physostigmine or only benzodiazepines, the trend still remained that physostigmine significantly improved CNS stimulation scores, while benzodiazepines did not. So the authors concluded that physostigmine significantly improved CNS stimulation scores, both as the initial and sole treatment compared to benzodiazepines alone. So your key takeaways is that anticholinergic toxicity often results from antihistamines, antipsychotics, tricyclics, antiparkinsonian drugs, or plant exposures. The unifying mechanism is muscarinic blockade, in producing both central delirium and peripheral signs of dry skin, mydriasis, urinary retention, ileus, and hyperthermia. Supportive care, cooling fluids, bladder management is essential, but physostigmine offers the advantage of directly reversing both central and peripheral effects. When used with caution and appropriate monitoring, physostigmine can prevent the need for intubation and reduce prolonged agitation or heavy benzodiazepine sedation. And one unfortunate but realistic point of physostigmine is that the only manufacturer of physostigmine has stopped producing it. So right now, the ability to acquire it in the United States is very limited. And here's their last knowledge check. The patients noted to be diaphoretic with hyperactive bowel sounds. Which toxidrome does this finding argue against? Anticholinergic toxicity, B, sympathomimetic toxicity, C, serotonin syndrome, or D, malignant hyperthermia? A, yes. Okay, thank you for your time and your engagement today. I hope this review of hyperthermic emergencies and their management was helpful. I'm happy to answer any questions. And here is your CE code. Christopher.
So you mentioned some of them like serotonin syndrome, like the study you mentioned, kind of like or like
Mhm.
do you have any thoughts or guidance on listing things with like MA or the
Yeah, so the question was, and several of the disease states that we discussed, we talked about weaning the treatment off, and if you would do the same thing with dantrolene and malignant hyperthermia. And I think particularly with dantrolene for malignant hyperthermia, you can continue treatment until the symptoms are no longer there. So that may look like a slow wean, continuing to give doses as the patient needs it, but if the patient's clinically improving, there would be no need to like redose preemptively if you expect them to resolve out of the acute phase. Emily? Yeah, so the question was, what was the mechanism between the calcium channel blocker and the dantrolene interaction? And that was really interesting. I looked that up because there's not a ton of information on it, but there are case reports of patients experiencing severe hyperkalemia and cardiac arrest after using like verapamil for arrhythmia management and severe malignant hyperthermia. So I don't think the mechanism is super well understood, but it is like documented. Yeah. 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 It's interesting. Kyle.
What should I do with all these delayed lymphoid factors?
The question was, what should I do with all these linazolid warnings that I get? That's a great question. Same thing goes with methylene blue and many of our other drugs. So really the point I wanted to emphasize in that section is having caution whenever there's multiple drugs and multiple different classes that are being used. So if there are drugs that can be paused for the moment while you're treating with, if an SSRI can be paused while you're treating with linazolid, if the patient's also on other serotonergic agents, that would probably be best practice. But if it's just one other drug, then there's like limited concern for using something like linazolid with an SSRI. Emily.
Similar question, like the interaction with fentanyl, you mentioned to avoid, but how significant is that an interaction? Like, is that something you absolutely would never do, or is that okay and just support someone through it, or
Yeah.
what's the severity?
Yeah. So the question was, what's the severity of fentanyl's contribution towards causing serotonin syndrome? And I honestly don't have a great answer for that. I think as the patient is on more and more serotonergic agents, you have to think about a risk benefit analysis. And if there are other agents that could be used in place of something like fentanyl. But if that's your option, then that would be something that I think you could monitor for and use with, judicious use. Chris?
Was there a tool they used for MS to determine whether it was severe, to know whether or not it's treated to stop it?
Yes, I believe there was a tool. Let me go back to those slides. So this is the kind of grading scale that they used. And like what this study kind of showed was that if the patient was in severe, moderate to severe NMS, then it would be you could benefit from using bromocriptine or dantrolene. So that's kind of how they classified. Yeah.
Like moderate to severe, I think it would, someone that they like Parkinson.
Yeah.
I think it's enough that within Parkinson that we still have to take adding it out.
Yeah. I think so. The question was in moderate to severe NMS, would it be okay to add back Parkinsonian medications? I think it depends on how severe the patient is and what else is going on. I think it would be appropriate to pause and then slowly reintroduce at like a lower dose the Parkinsonian medications. I don't know. I don't know if there's a right answer for that. Okay, it is 1 o'clock, so we do have to evacuate, but thank you guys. Thank you. I wondered who that was.